there? I don't know. Because everyone else seems to be there.
Uruna also joined. Uruna, I haven't seen her.
Yeah, she's here.
They are only. That's right.
Can anyone call Amrish maybe?
Amrish is joining. Aruna spoke just now.
He is here. Okay. Okay, so we have the panel now.
Yeah. Yes. So there are almost 24 participants. I think we'll start. So good evening and welcome all. Welcome all to this series of in-depth academics. And we all know about ERAS, that is Enhanced Recovery After Surgery. And we know that these changes that are done in the immediate perioperative period, these protocols that are being followed have definitely improved surgical outcomes in patients in orthopedic surgery, colorectal surgery, various gynecological surgeries. But what is their evidence and what is the feasibility of maintaining these ERAS protocols, especially in extensive surgeries like CRS and HIPEC, is what this panel discussion is going to be about. And today we have Dr. Geetu Bhandoria with us, and most of the PSM community know him very well. For others, he is a very senior and a highly experienced gynec-oncologist who has worked extensively on ERAS and maintaining its protocols and setting the protocols, as well as having he has a lot of publications on ERAS. And he's also worked on developing ERAS consensus for cytoreductive surgery and HIPEC. Dr. Geetu, over to you. Thank you so much.
Thank you, Dr. Avana, for the kind introduction. Good evening and welcome all. Before I start, just a simple housekeeping rule. Please keep your mics on mute. In case you have questions, please feel free to type and we'll try to answer as many before we finish. Today, we are going to discuss about enhanced recovery in CRS with or without HIPEC. We are not going to discuss the basis of the guidelines or whether the guidelines are strong enough or evidence-based enough, etc., etc. We are going to discuss what are the possible challenges that if we face any, and what could be the solutions to these challenges. We all are aware of the enhanced recovery protocols, pathways. These guidelines have been there for over a decade now in practically all surgical fields, including oncology, including peritoneal oncology and CRS and HIPEC. So we are going to discuss. Yeah. So I have the easier job today of asking questions, but we have a diverse series of panelists representing from north to south to west. Dr. M.D. Ray, who is a senior PSM surgeon at All India Institute, New Delhi. Dr. Jayaprakash, who is a surgical oncologist and PSM specialist at Fortis Gurugram, not Gurgaon. My friend Rohit from Aster Hospitals, Bangalore. Dr. Deepthi, who is sitting with Dr. Aruna. Both are from Thangam Cancer Center, and Dr. Amrish, who's at Apollo Hospitals, Nasik. So this is just a snapshot that there are guidelines which are existing for some time now. I assume that the guidelines are under revision, but a large panel of international experts representing different regions of the world came together and came up with these guidelines. We did our own consensus some time back and published, which is in consonance with the existing guidelines. So guidelines and consensus documents are already there as far as ERAS in CRS HIPEC is concerned. Now, as I mentioned, our focus is the challenges. So yesterday I posted a small poll in the WhatsApp group that what are the challenges people face with the responsible list, but only two options were chosen: lack of ERAS trained personnel and patient barriers. So now my question is not to any specific panelist, but probably all the panelists can share their own experiences. Some of the panelists have had their own publications and experience. I'll be sharing that. But to start with, can the panelists, maybe starting from Dr. Ray, can you share before and after story? You have ERAS publication now.
Sure, definitely. Because what happens, ERAS, that protocol and whatever you say, the guideline, ERAS guideline started in 2020. And we are practicing I think last, say like 12, 14 years, that. But practically, unknowingly, sometimes we follow this, sometimes we don't follow this. The question is there, but that is why the challenge is there, because that is not it's a heterogeneous kind of disease. So you cannot compare with the ovarian cancer and even the different settings, even in appendicular, suppose say even PMP, huge PMP, or suppose early PMP. So that's the kind of heterogeneous disease. And that's why the problem is there, the challenges are there. Even not only you are alone, there are so many staffs also involved, your anesthetic colleagues also involved. So, but on the passage of time, whatever after this guideline sort of thing, after this study, so now we implemented that thing. And what happens, because being a part in the tertiary care center, we could do it on the study basis. That is the benefit from our side. So as I have given one a thesis study for one of my students, and recently we published this thing. You must know about this in Journal of Surgical Oncology. So means initially we used to practice, but not in the systemic manner. So presently we started doing in the systemic manner, but there are different challenges are there. So should I talk about the challenges, or other people can say, then we can go
Yeah,
ahead?
we will take everybody's point of view, sir.
Right.
Rohit, your center, both the current and the previous one, have probably a more streamlined approach to ERAS. Do you want to share your experience?
Sure. I think probably one of the most important factor that we are missing when we are talking about auditing ERAS is about having a neutral coordinator who is watching you outside of the team who is performing the work. His job is only to see is the people who are involved in ERAS following it up with what they're supposed to do. Most of us always feel as clinicians that we are doing everything, we are doing everything, we are doing everything. So the missing link in the ERAS probably would be the ERAS coordinator whose job is mainly to just unbiased record what is happening. So when we ourselves audited ourselves, when before our we had external auditor who was most of our team members had been to Switzerland for the training. It was trained in the institute there. We are all ERAS accredited surgeons, all our team members in our team. That was only for gynec and colorectal. So for ERAS and IPAC, we still do not have any accreditation centers or any laid down principles like how it is there for colorectal and gynae onco. So once you finish the training there, then you will have a software that is being installed into your system, and you will have an external coordinator whose job is only he comes keeps on like a food inspector who's inspecting, just coming and telling food hai acha hai nahi hai, khao dekho jao. So his only job is to see, did surgeons do their job, is preoperative done, intraoperative done, anesthesia did their job. That's all it is. So when we saw an unbiased person coming into the field, we saw there was a lot of compliance reduction. What we thought is something is there is actually not something is actually happening there. If you go in terms of strict textbook prescriptions or the lines of guidelines. So probably what they have mentioned here, what in your group WhatsApp is mentioned, that lack of ERAS trained personnel is one of the probably very important factor. And also we do not, in India, we do not actually push towards having a nursing coordinator or somebody external of the clinical team to come and audit us, or who is a chain to the clinicians of everybody. This
Correct.
person makes a big difference in ERAS implementation.
So
Good. Yeah.
can I make a comment on Dr. Rohit? Actually, whatever you are telling, that is ideal kind of thing is there. But before that, what I believe personally, you have to have a compliance sheet. At least your student can fill up this compliance sheet. You can see this, the strict adherence with the which part, which items, which is not. So initially you can start in that way. Then what you are telling, that is very ideal. But initial phase you could do like that way. The compliance sheet is very important, daily compliance sheet.
So what I meant was the same thing. Somebody external outside of the clinical team by taking it into consideration, not
Who
somebody
is
who
that
is doing
person?
the
Who is
work,
that person?
clinical work.
Who is that person could be like?
That
Suppose
is what.
anybody
That should be a neutral nurse coordinator whom you exclusively appoint him for following it up. That's all. His only job is to unbiased evaluate every clinician.
so that
Without
is
even telling them, you're not
that is
doing this.
possible. But that is possible. But private setup you could hire like that way. In government setup, particularly in for the ERAS one appointment one nurse is slightly difficult this thing, but that is ideal. I can believe in that. I agree with that.
So that's the idea of this discussion, that what are the key challenges. So I'll ask the other three experts. We have Dr. Jayaprakash.
Yeah, hello. So I think what Rohit was telling, actually it is true. We should have an ERAS coordinator, because the ERAS is actually a teamwork. And the problem is ERAS is actually whole team is not on the same page. So someday you have to discuss with something with anesthetist, the anesthetist changes for the next case, then you have to discuss with the intensivist, then nursing and all those things. So I think we should have an ERAS coordinator who is an independent one, who just coordinates the team, see whether surgeon is doing his work properly, whether an anesthetist is following this, whether the ICU is following this. As a busy surgeons, we cannot do all this actually every time. We just go for it, but we cannot do every time for this. And the most of the time, the challenges come from the anesthetist, because different anesthetists have some different idea. And I also think that we should involve them early also. If we don't involve them early, they just consider our demands as surgeon is demanding, but actually it's not. So we should involve them early so that they feel ownership, they feel like they are also part of this ERAS or something.
Yeah, thank you. So like Greg Nelson, who I worked with a bit, he says there are three champions of ERAS, or three key pillars in any ERAS practice: the surgeon, the anesthesiologist, and the nurse. So unless these three pillars are standing, the ERAS program is likely to fail. Dr. Deepti, what is your viewpoint?
So, what I think this ERAS is a way of living. It's not that one day we decide and just can we jump to the ERAS. First, the people who are involved with what you told, surgeons, anesthetists, they should first believe, okay, this can be done. So, which is the most difficult thing. And that also comes with the experience, because it's not that the first surgery is the CRS. For many of the surgeons, they do extensive other multi-organ resections, and the ERAS is known for other things also. So we cannot, the main concern, it happens what we are seeing, we also follow our ERAS protocols. So suppose there are varied things. Somebody wants to take out drain early, somebody is putting drain in the thorax. So those key areas are very difficult to convince until you are experienced for that. So it will take time for everybody until you have gone through the journey. It is very difficult to implement. And there are so many components, pre-op, intra-op, post-op. To align all those components, it is difficult, that all the box cannot be ticked at the one go. It will take time, and it should be based on the case-to-case basis, depending on the disease and type of patient, which we face, that we cannot just apply for everybody.
I agree. It's a team effort. The team has to be aligned. I've had this discussion before with other national, international experts, and they say the only way to probably implement ERAS is that first we have to identify, do we really believe in it? Because a lot of us feel like, oh no, I have learned this in my training. I was taught by such a such senior teacher or whatever. How can I change? How can I not put a drain, or how can I not keep a patient fasting so many hours, or how can I not do a bowel preparation, etc., etc. So the need for change has to first start. I mean, do you really want your patient to recover early. There could be other factors that your hospital doesn't really want the patient to leave the hospital early because there is a financial element involved. Yeah.
Dr. Gitu, it's other way around. For the
I-
hospital, after first 3 days, there is losing income if the post-operative patient stays in the hospital.
Absolutely.
Studies are there.
Every day
It has
lost is
proven
money
that.
lost. Because
Yeah.
it's you are preventing a new patient, a new surgery, a new big thing. So every hospital would want to send the patient as early as possible, because after first 3 days, there is no big revenue for the hospital from patient's point of view. That is
Good.
why I think ERAS has taken a big push.
Good. So Dr. Amrish.
Yeah, so most of us have already shared. One small input which I feel is that most of our surgeons are practicing as general surgical oncologists as well in gynae onco and other surgeries. Introducing ERAs in other cases is also important because that trains the staff and the anesthetist, and pushing them like only for cytoreductive surgery would be like somebody is doing once a week or twice a week or maybe once in 2 weeks. But if you inculcate the values of these ERAS modules into the day in like colorectal surgeries, gastrectomies, even if you do an endometrium, that way it imbibes that culture in the staffs and the anesthesia. I personally feel that it's difficult for the existing generation of nursing staff and anesthesiologists, those who are not in that environment of an institution where the newer methods are being introduced, for them to adapt and change. It becomes a very cultural shift. So it's important for the newer generation to inculcate, I mean the train the newer generation of anesthesia and staff nurse, those which are younger, those who are more adaptable and more easily ready to accept things. And then we have to make a structural shift here, because just by enforcing, like a small example, I had a one of our anesthetists said she will not put epidural for CRS. And I said, why? He said, no, there will be fluid shift, there may be coagulopathy, there will be some other. So I said, but I'm, what is the point? The epidural analgesia patient is having going to have a scar from xiphisternum to pubic symphysis. And what is that? So I had, there was, into inculcate even such small things like we have to have an epidural, multimodality analgesia is important. So these things are important. So it's difficult to teach already trained who are already in practice, but we have to inculcate in newer people generation. And even in other cases is what I feel, there's that in smaller surgeries like colectomies, gastrectomies, over uterine cancers, such way.
I completely agree. So probably the solution to this is that we keep talking about ERAS protocols in whatever academic meetings we have at our institutions, whatever conferences that we have, so that more and more people get exposed to the concept. It's not that the anesthesiologists are not aware of ERAS concepts. A large chunk of ERAS protocols involves anesthesiologists. In fact, the modern fasting guidelines at 6 hours for solids and 2 hours for liquids came from anesthesiologists. If we trace back the genesis of ERAS guidelines in colorectal surgery, which was the first guidelines to get published. Now, I would like to ask the opinion of the panelists that people have mentioned patient barriers. So what is the patient barrier? Most of the patients say that you do whatever you feel is the best for me. So how does the patient become a barrier in implementation of ERAS? An open question, anybody can take it.
So I will tell you, as far as the patients are concerned, I think most of the patients now still feel that rest is recovery. It's a huge challenge actually. They think that it's a major surgery, so we should take rest and it will help in recovering. Whereas it is opposite actually. So we should mobilize them early, and the same for the early feeding. Actually, they say that they are full, they just want to take rest, they want to give rest to their stomach, but that is not right. But actually, it is a very big misconception among the patients.
Anyone else?
Exactly. I think, ma'am, please go ahead, ma'am.
Yeah. So the thing is, again, there are few barriers to again start with the pre-op. See, pre-op, when we counsel them, the counseling start with a quitting smoking, alcohol, and good nutrition, all those things. So we counsel them. We do not know how much adherent they are to that protocol. First thing, intra-op definitely they are not involved. The post-op, exactly what sir has mentioned now, that it is sometimes they are interfering. Why you are because nowadays when they are more informed, and more of the rest, they resist walking, they resist some physiotherapies, and so how fast you are taking out of the patient. We want to stay back more in the hospitals. So the main thing which has reduced ERAS has reduced the hospital stay, but they are against it. They don't want to go back home in 7 days. They want to stay back 2 more weeks like that. So each component, again, there are some things which are as a patient barrier, which we notice here.
So one important thing, Dr. Deepti, I just can mention about that, my experience. We ask always the patient for the prehabilitation, and most of the adherence with the prehabilitation in compared to the intra-op and post-op. But if you see this, but we always advise for the prehabilitation, like you do the spirometry sort of thing is there. Even so many patients I see, you won't believe. I ask them, and then when they get admitted, I see this, you show this, how to do the spirometry. Even they didn't purchase also the spirometry. It happens because that is kind of practical things. Suppose say we ask to have their hematinics also, they hardly bother to do that. Even meditation, exercise, all these things, the preparation, all the prehabilitation formulas. But that is also our duty to check that. Practically so many times that they are not stick to that. So sometime now I started what I do, I ask the patient to come to my OPD when just before getting admission. So we see this thing, you are doing spirometry or not, this thing, I check this thing. That is also important. Not only advice to the patient also, we are our duty to check also whether that is being implemented or not.
Correct. Dr. Rohit, did you
I think Jayaprakash sir said it absolutely the right way. The cultural feeling of Indian patients. This is what I would tell probably, that it is in the mind. Hospital में जाएंगे तो सोएंगे, सोएंगे तो अच्छे हो जाएंगे. This is there because they are all, when the patient is so sick, when they go to surgery, they feel that until and unless entire family comes and just keeps on seeing them lying down on the bed, that is not complete, meaning hospital journey is not complete. So it takes a big amount of push to the patient right before even they start of the chemotherapy. In fact, many of our patients also, the counseling is at the beginning of chemotherapy, not even before surgery we are talking about. From then on, we keep on meeting them, we keep on telling them. So what we have found more easy to convince patients specifically, to get adhered to these things, specifically mobilization or physiotherapy. The most important what we felt was anchoring the outcomes to finances, or anchoring the outcomes to their going home early. I just tell the patient, go whenever we go for rounds or whenever we, even before the admission, we tell them, अभी आज फिजियोथेरेपी करेंगे तो घर 5 दिन में जाएंगे, नहीं करेंगे तो 25 दिन में जाएंगे. तो आप चूज करो आपको 5 दिन रहना है, 25 दिन रहना है. आप चूज करो आपको 5 लाख पे करना है या 25 लाख पे करना है. सो द मोमेंट यू हैव अ एंकरिंग थॉट फॉर द आउटकम्स, they feel okay, it's their responsibility. So the most important thing what we also doctors and clinicians feel in India is that we own the responsibility for patient's recovery, and we take it too much into that, not allowing the patient to take that responsibility. If the patient doesn't take responsibility of their own coming out of things, then this is not going to happen. As they tell, you need 2 hands for a clap. Both the patient should be told that you are responsible for your health. We just tell them directly, आज 10 घंटे का सर्जरी हुआ है, my responsibility for you is done for today. कल से तुम्हारा responsibility है, तुम्हें walk करना है, तुम्हें exercise करना है, तुम्हें mobilize करना है. We will guide you across, but आज से your responsibility. So we take that privilege from the patient, just because that has been how we are also going ahead. So I think this also requires, whatever everybody is talking around, a change for every aspect of thing. It has to be either ways. Everybody has to push for the responsibility to understand it is everyone's responsibility to take the patients out. I think because of proper counseling, they will definitely do it. It is just that we are not, sometimes we are also holding on to the responsibility, telling I am responsible more than what you are responsible.
Yeah, correct. So I think that is the exact role of an ERAS nurse, because obviously as clinicians, we wouldn't have so much time to individually sit with the patient and counsel about the pros and cons of different aspects of the extensive surgery she's going to face. So that's where a dedicated nurse or a paramedical staff who is sitting as a counselor and who explains to the patient that the concept of bed rest is no more existing. So this change of thought process needs to start way before the surgery. Only then the patient probably will be prepared that, yes, I will be able to leave the hospital early or leave the bed and move around and eat and everything. So I completely agree. Now, what about the resource crunch? I just mentioned the constraint for time. We all are always short of time. We are overworked and hard pressed for long surgeries, and then managing the OPDs and everything. So is there a financial constraint? Is there a financial element involved? The panel, if you want to implement the ERAS.
Oh, only if when government schemes are involved, that could be a possibility reason where financial constraints are there. Only if the patient is, that is the point, maybe a rate limiting step to for from the anesthesia, ICU, and other aspects.
No, like I just mentioned, and Dr. Ray mentioned earlier, that like Rohit was mentioning that we need to have a ERAS coordinator. So who is this coordinator? I'm mentioning about an ERAS nurse. So that means extra manpower or extra personnel. So dedicating one extra personnel means using the time of that individual. So could that be seen as a financial constraint and an additional burden on the resources available? Rohit, what do you think about the financial element?
Sir, everywhere, wherever we are talking about, ultimately it comes to return of investment, meaning ROI is what everybody looks at. If you look at purely in terms of financial perspective, like imagine you are somebody who is like a core market guy who is thinking how much should I invest here and how much will I get. If we exactly do the coordination team with the coordinator and auditing of the system and show the management, this is what the hospital is going to get, I am 100% sure every hospital is going to push for this. It is just about making it more practical and telling them how it has to be done. Somebody has to push. Like literally, I would, I would really put it all to Dr. Somshekhar, who really pushed us in terms of thinking and the boundaries of how we can push these things. So when somebody is there, then only you see the difference. Most of our outcomes improved a big way. More than that, hospital feels so happy that a patient who is supposed to go on day 8 is going on day 4 or day 5. Imagine 3 days extra, how many patients, how many revenue, you look at a bigger term. So hiring one person, you will be getting money equivalent to more than 10% by that person alone itself. He's going to drive. But the point is, how do we show it? How do you show it? Is not like, as easy as in market just by marking it in green and red. It is very difficult. That is where auditing becomes a big challenge.
So there was actually a study done by Greg Nelson in Canada that they did this financial analysis of a small cohort of patients where ERAS was implemented through the ERAS implementing organization, which I'll share a little while after. That $1 of investment in ERAS actually implies or converts to $3 of savings. So it's actually a 3 times saving, but you're right, it's not going to be like the day you implement it, it's going to show. It's going to take time. There is going to be sort of a learning curve, like Dr. Deepti had shared her inputs. So is there a learning curve for ERAS? Yes, there is, because it requires at least everybody to think alike, everybody to be ERAS oriented, and whatever different surgeries you may be doing, each surgery has its own guidelines. So you will finally have a checklist. It's a checklist based protocol. So you comply with the checklist, and maybe after few months, you will start looking at the returns, like you just mentioned, the patients going home earlier and more beds are available, you can probably do more surgeries, and it actually leads to more revenue generation for the hospital also. What about the administrative support? Like we briefly mentioned about it, but are you feeling any challenges from the administration, or administration like you do whatever you want, we don't care, or if you ask for extra manpower? Yeah.
Yeah, here I'll just cover these three also. What we were discussing in a broader aspect, if an institute or a place which are doing lot of many other surgeries, like for us, we are doing a lot of major thoracic surgeries and other organ resection. So it's not that ERAS coordinator, the person who is responsible, the resident who are involved, they are not only one CRS and PSM group. So it's again a way of living. If you invest in one person and that shows the result, then definitely administrative, financial, all those things are on the secondary part. Nobody is worried about that. But again, start to convince the people from the newer who are joining you. They are coming newer consultant, or the doctors who are coming with the new ideas, even anesthetists or any team. So how valuable this is. So if a good team is ready, is coordinator is ready, it is a multi-purpose. We can use them for all other purpose here. So all these things are actually not the crunch. It's that we have to accept and go ahead. We have to show the results.
Anyone else has any inputs?
Sir, with respect to what you mentioned about the expenditure, this is how the practical ERAS expenditure comes to. So if at all you really want to be ERAS accredited by the NCare Society, and you want to put it on your hospital that we are ERAS accredited, NCare accredited, it accounts to lot of money, to be very frank. So when we were, when we were put into that, it was through a partnership with one of the this thing. So every person training itself accounts to more than 25 to 30 lakhs. And then more than the person training, this system, this software which the NCare system puts into your computers, and the annual maintenance of that and continuation of that itself becomes a big amount. So if you are going in terms of the expenditure with NCare itself as a standard and telling it is because of NCare only my ERAS is there and I am only because of that, then it is going to be a huge amount, which I don't feel it is a practical way of living for any of our Indian institutions. And as everybody knows, we are the best jugards in the world. There's no doubt in that. So we have our own way of auditing and monitoring. So probably I think it is the time that we have our own group of people who come on to a system to tell we will have an Indian way of setting up the NCare accreditation sort of thing, or some society accreditation, if you want that for the sake of naming yourself as some accreditation. Otherwise, most of them are doing it. It is not that we are not doing it, but are we doing it in right way? Then comes the software accreditation, the software application. When they come and check each and every point of yours, each and everything is being audited. Then they tell you, okay, only if you cross this much percent, you are the accredited person. Then you become center of excellence. Then you start to invite those things and aspects of it. So if you look purely in that terms, it's going to be a lot of expenditure. I don't think it is needed for any one of us.
I agree. NCare is the only company, and it's a private firm, so they do charge a lot of money, but ultimately it's just again that checklist, ensuring that the checklist is there and somebody is sitting and doing that. So ERAS audit is one of the key elements as far as implementation of ERAS. So that, are you really doing it? Are you really crossing the 70% minimum cutoff to call yourself as truly implementing ERAS? So there was a text from Dr. Aditi.
One important thing regarding this context, because they are practicing in private. I am in the premium institute. Government support is much more. Administrative support is there. You are in the military settings. That also important. How much support you are getting from the different settings. From private, they may get this thing because of the benefit of that. Here the manpower is lack. So that's we are managing everything by our students. Your things are altogether different in military. So how you implement this kind of thing is there. That you can share your viewpoint also.
No, so it's completely opposite. There is absolutely zero support.
That's what I'm telling, because they are telling from their aspect, because they are practicing in private, and our aspect is altogether different.
Yeah, that's why I touched on this point, that these are the practical issues that yes, we are all aware of the guidelines, but how easy or difficult is it to implement them? It is difficult because you need dedicated people to help you at least collate the data that okay, somebody has to fill that checklist, and then you have to keep going through that checklist. That what is the compliance rate? Only then you will start seeing results. Otherwise, probably in bits and pieces, we all are doing some of ERAS, and that's what our previous surveys have shown when people obviously try to over report that yes, I believe in ERAS and I do do implement
So
it.
that is, you rightly said that some ERAS, not complete ERAS.
Yes,
We are
yes,
doing, everybody is doing some ERAS. That's
yes.
true. Mm.
So moving on to what is the evidence. So we have the guidelines and the consensus, and it is heartening to see that some of our institutions are now coming out with their own experience studies. So the authors of these studies are sitting in the panel, and that's why we wanted to have their opinions. Of course, they had their own their challenges. Then we have a recent international multicentric study also from centers representing Europe, North America, and India. Again, you see Rohit's name there. Yes, somebody wanted to say something? Okay.
Regarding the evidence, I can say, Dr. Gitu, actually there is no level 1 evidence is there at present. But the ERAS guideline that has been established in 2020, and before that people practicing. But I feel most of the study, if you see, that is observational study, single institutional study, and few studies are there, that is a collaborating study like this one, you shown this. So that's why I cannot say that strong evidence are there, but evidence is enough to start the practice. That I can say in a word.
I agree that there are relatively very few randomized trials, and that too all the elements. There are so many elements if we go down to nitty-gritties of the entire protocol, especially in CRS HIPEC, that it may be extremely challenging to do a randomized trial for all the elements. But evidence is accumulating, and people are getting more and more experienced with the implementing, and there are discussions going on that which elements are the most challenging ones, how we are going to address those issues. So when we look at the different elements, then are truly all elements applicable, and if not, then which are the most difficult to implement? So this is just a snapshot from our consensus, which you can see that there are so many different elements starting from prehabilitation, intra-op, post-op, pre-op. So a huge number of elements. So now I would ask the authors from Dr. Ray, which elements did you find the most difficult to comply with in the checklist or in the ERAS guidelines?
So that is true. Most of the thing, if you see the study also, and that is practical, most of the adherence with the prehabilitation. So that is everybody accepted, because that thing we have to correct the nutritional status, we have to correct the anemia. This sort of thing is there. Almost everybody, that adherence is more in that. But what happens, intro, like suppose they earlier another speaker was talking regarding the intro, because your anesthetically that is important. Suppose before that, 2 hours before, if you just ask for the to have some fluid kind of thing is there, they are not agreed with that, because I say that is called psychological indication of the surgeons, or psychological indication of anesthetist here. Because what happens, sometimes it happens one patient aspirated, and because they stop doing this thing, that anesthesia is very reluctant to do that. That is also important. We cannot do anything practically. Have you pushed anybody like 2 hours before you put this thing fluid, as like 100 grams glucose, or 200 ml apple juice? So practically they are not, they are very much reluctant in that. But when we started our protocol basis, we are giving the thesis to our student. Then I have taken one anesthetist who is very much like, means he's willing to practice in that basis, evidence-based ERAS protocol. So I took him only. So that is the heterogeneity is there, because they believe the long fasting is required, not 6 hours, and no fluid challenge, just given to the fluid in 2 hours before that. That is one of the important challenge. Number two is the opioid. Particularly there is as per the ERAS protocol, that strict opioid is there or opioid free. But hardly they practice this thing. They use hardly all opioids there. So that is one important thing. Even the regarding this thing post-op extubation, that is also one of the challenge. Most of the patient, when the extensive surgery is there, patient is hemodynamically unstable, they hardly extubate the patient early. So that is also from their side. So that is from anesthetic side I am talking. From the surgeon side, if you see, and extensive surgery 6 to 8 hours, then you ask the patient next day, and same day, suppose a patient distension may be there, bowel ileus is there, and you ask the patient just or your resident to take the rice tube out for that. So that is practically like somewhere you feel hesitant. Like I feel personally when the extensive surgery there in colorectal surgery or small, suppose say low PCI any surgery like in pseudomyxoma you can, but in extensive surgery I hesitate to that remove the rice tube, particularly when the upper abdominal, particularly the stomach resection is there, sort of thing. So that is one thing is there early mobilization. You think about that when the patient extensive surgery, how you ask the patient within 24 hours is the mobilize this thing, mobilize. Practically that is slightly difficult. Patient not like that way motivated, and because in the extensive study it's very difficult with the so many tubes, even the fluid channel, so many things, and then ask the patient to mobilize. That is practically also difficult. So these are practical things. Even the you just implement the oral fluids or liquids in the same day or next first post-op day. Even if you do after this, particularly the anastomosis, bowel anastomosis, that is also challenging kind of thing. So I believe, particularly in its short, I believe you have to segregate which kind of patient you apply, which kind of ERAS like this. So my concept is there, consensus, like you fix this thing for which patient you are going to do that. So initial not only 72 elements you have to apply. So you just apply like suppose 12 to 20. In our case, this is a high volume center. We applied in our study 36 elements. So that is a good enough, 50% at least. So this kind of challenge is there. Plus minus on the passage of time, I think you realize and you modify this your practice.
Dr. Deepti?
Yeah, very practically told. And if you ask us, all these are prehabilitation, intraoperative, and others are not that much of a challenge for us. But we also face post-operatively. Three things what comes in mind is, first thing what sir has mentioned, the early removal of NG tube when the patient will, obviously we see that there is some distension and extensive surgery, patient may go into the ileus. Second thing is we are still not able to, after diaphragm stripping, and not able to put ICDs and reinsert it later on. That practice, drain practice, we are still in conservative. And the third one is use of opioids. Sometimes the thing is that we need to use, although we are avoiding. All other, I think so, are easily pre-operatively. Actually, if you explain such a big surgery we are going to do, patient get convinced and they're following those things. Intraop is in our hand. If it is a good team and understanding anesthetics, it is not a difficulty in private setting, correctly sir told, because it's a small team and for long we are working along with them. So that's easy. But these post-op thing, we are still removing the catheter. Sometimes patient is not getting mobilized. Yes, we can remove after 3 days or 4 days, but these drain, opioids, and NG tube, these are the three things which we face. We are not, everybody we just take out by protocol. It's a patient to patient basis. We have to just change our protocols.
Agreed. Dr. Jayaprakash, do you have any additional inputs?
Yeah, I agree. Actually, during intraoperatively, we are at the mercy of the anesthetist. You should have a good rapport with the anesthetist because all the points are in their favor. So for the post-operative, we also face challenge. The first is for the NJ tube, and the second I feel for the drain also. In ERAS protocol, they say early removal of the drain, but how many of us will be comfortable in removing the drain when you have done, suppose, anastomosis, any colon resection, or you have taken out deposits from the bowel and you have put sutures there. When you close the bowel was so much edematous. So I am not just after doing anastomosis and all, I am not okay removing the drain before at least 5 days, actually. So I just don't know how ERAS people will be comfortable, because then if suppose patient develop fever, then there can be 100 causes from anastomosis leak to the non-surgical causes. So if you have removed the drain, you will be always worried. So we better keep the drain there at least for 5 days. But I just don't know how ERAS has advising to remove the drain early, but still I am not comfortable. So we cannot put that. Same for the RALS tube. So not all patients will have distension or that kind of ileus, but if one patient has vomiting and all, his whole experience goes bad after that. So we are also a bit conservative in removing Ralph's tube unless I am that sure that abdomen is soft or the bowel sound is reappearing. I am not comfortable removing Ralph's tube.
Dr. Amrish?
Yeah, so after listening to everybody, I feel there is a little bit of how would I put it, hypocrisy in our thought process, wherein we want the ERAS to be followed. We want that patient should be minimally fasting, but we don't want to remove the drains early. That's okay. Everybody is entitled. We are all same too. Even I don't follow everything. I feel what here is that we have to tailor it on basis of the surgery that has been done. We need to understand anesthesia, surgeon, and the staff. They all have to have a basic understanding of what the parameters of ERAS is. And then each surgery has its own merit, due and requires its own merit, whether this patient needs early removal or does not needs delayed removal. An instinct of the surgeon will tell whether the surgery has gone well or whether there are some concerns regarding bleeding or leaks, whatever. So I feel, for ERAS overall, yeah, there has to be an understanding between what the anesthesia they have to have an understanding about the anesthesia aspect. Surgeons should have an understanding of the surgical aspect, and the staff nurse also. One important thing where I feel we can make a difference is the pre-operative thing, which Racer also, because that is where is what is that is something which, how do I put it? It can be enforced upon, or rather we can do it more rigorously based on when the patient is just started finish, maybe the patient has just finished his chemotherapy, neoadjuvant chemotherapy, and we are planning a surgery in the few weeks later. So that is the time period that we can capture upon. But whether when to remove nasogastric tubes and when to remove drains are a very subjective thing and depends on case to case basis. So whether to generalize that and to follow and to make it like a SOP is difficult. The same with anesthesia point of view. We have to respect whatever they want. If they want an overnight fasting, that's okay. Let them have an overnight fasting. It's not going to make a big difference. But this is where I feel that is the time, because a patient who has low protein intake and low, they will have edema, they will have some problems, they will have issues with fluid balances. So these things are where we can tap upon. But otherwise, it has to be a more liberal thing, not a very enforcing thing. It has to be more liberal.
Okay. Rohit, since you have the NCARE implemented and ERAS accredited, which elements are the most challenging?
In fact, what we did was the other way around. We thought, who is the villain? Ultimately, everybody speaks that anesthetist is the villain. So what we did, we turned around the page. We told in our hospital that you will be the one who is going to lead the ERAS program. We made them heroes of our ERAS program. So we have least resistance in terms of anesthesia now. In fact, actually, a lot of things which we were against, they fought with us telling, why are you not doing this? Why not to do this? I'll give you one small example. There was a mention about epidural anesthesia regarding use of epidurals. Even we also had the question to them. We asked them, if you put epidural, we do extensive surgery, patient is already hypertensive. Why do you post-operative anyways are not going to use? Why do you want to put epidural? So my anesthetist told me, see, my putting of epidural is not just for post-op anesthesia. It reduces my use of intraoperative morphine also. There's a lot of intraoperative things. In fact, if you see the first chapter of Bailey and Love, in which it is so clearly mentioned the impact of doing epidural anesthesia, how much the stress response is blocked for that patient. So, there are a lot of things where you can always turn around the pages and tell, okay, this is how we were thinking against and they were not with us. So it is always, we are like always the Tom and Jerry of the real life. And so both of us would want to push each other to become the best of us. And definitely agreed with everybody's point of view. There is no doubt with what everybody mentioned and how Amrish finally summarized and told. It is left to that surgery, which even Aditi ma'am has mentioned in the comment. The following of ERAS has to be, especially in CRS and HIPEC, depending upon the extent of surgery and HIPEC done or not done. So it is going to be what madam is telling again and again, a way of life for every individual. It cannot be one way of life for everybody. And so out of 72 elements, how much can you take in this patient is going to be the big difference point over and over and above. It is not like for every patient we have to remove the catheter on day one itself. So in ERAS program, in ERAS decisions, whatever, if you see, you can see there are modifications made for that, particularly regarding that. So if you see in regular ERAS, catheter has to be removed the same day. Whereas in CRS and IPEC, we have got 3 days of that extra thing there. In case of Riles tube, they have particularly mentioned practical point of view. What if you're going to touch the lesser omentum, meaning that is where the crow's foot, the vagus nerves actually comes and goes into stomach. There is very high chance of gastroparesis. So that is when they have mentioned it. If you are going and removing lesser omentum extensively, then you are excluding from yourself by not pushing or removing the Riles tube on day one itself. So there are every element which have been debated, which have been looked in either aspect of view. So we need to just understand how best we can put those things into perspective, understanding where it has to be done, where it has not to be done, in which patient we can get the maximum complaints, in which patient we are not getting, and what did we learn out of that. Did we come out of that audit and see that when I did do this, something happened, or when I did something didn't happen? And as madam is telling again and again, it is just a way of life. And our way of life is not going to be one way from the day you're born to the day you're going to die. You are always going to see what is the motto. You enhance the recovery. That's all we are looking at. We want to enhance the recovery by living a best way of life for that day with the basic principles.
Very nicely put, Rohit. What everybody's saying, the studies also are saying the same thing. So this table which shows the low compliance rate, this is from one of the Indian studies. So again, it's the nasogastric drainage, the compliance is lower, early removal of catheters, post drains, mechanical bowel preparation. So, and this is the international study, and same thing, you can see the abdominal drains, very low compliance, 40%, 29% not using. Extubation, early extubation, use of opioids. So it's not that what you're saying is not true. It is completely true, and this is the same thing which is being felt by surgeons and researchers across the world. So yes, these are the intraoperative elements, some of them, and post-operative elements probably is the most challenging aspect. Prehab and preoperative elements, most of us are able to comply and adhere to more than 90%. So this is what Rohit was mentioning. NCARE is an organization which formally implements ERAS protocol in your institution, but it's an investment of thousands of dollars or euros. If you convert to Indian currency, it comes to a few crores. So, which is a huge investment for any organization or institution, especially government ones. So it is an expensive affair, but yes, probably it's time to maybe
அந்த டைம்ல வந்து you check with the LS search kit also.
Please mute yourself.
அந்த டைம்ல வந்து ஒரு 2 days to 3 days நீ ட்ரை பண்ணு.
Are there any final comments? I am saving some time, I guess. Just 5 minutes. We are having an ERAS World Congress very soon, where I'll share all this inputs. I'll be going there. But any inputs from anyone? Any?
Dr. Gitu, from my side, what I feel particularly in PSM, there are different cancers are there, starting from ovarian cancer, colorectal cancer, gastric cancer, mesothelioma, pseudomyxoma. So there, I personally feel we should make individual ERAS protocol for individual disease, because we are now living in the era of the precision medicine. So why we'll put together all the disease together and making 72 points like that? So that is not there. So what I do, I did particularly, I just for every patient, for pseudomyxoma periodontitis, I just make this thing, we'll follow this one. If the huge PMP, I'll follow this. If the low PMP, I'll just low PCI, I'll follow this. So that's why I made my own protocol. And my results are very good. I think that is most important thing. And those who are going to start the ERAS, They should start from not for the all. We should not blindly follow the Western literature, all literature. Make your own protocol, see your observation, and just adjust accordingly. So that is my point of view.
All right. Dr. Aditi has asked a question about bowel preparation and DVT prophylaxis. So, what is your practice?
So in bowel preparation, not all cases we do the bowel preparation. In our cases, what we do, I just modify it with that. In suppose say in bowel involvement is there, definitely we do this bowel preparation. Left-sided colon, any kind of loaded colon is there, normally left-sided colon. So then I do the bowel preparation, and patient having the history of constipation, long constipation history is there. I do this thing, and I do the 40 hours before that, not before only 24 hours before. That's why the spillage is more in this, and really that kind of makes an awkward situation. So that only 3 indication I just do this bowel preparation. Otherwise, normally, routinely we don't do. And that is regarding bowel preparation. Another one question was there from your side?
DVT prophylaxis.
Definitely, because in CRS hyping, you know, there is a chance of, like if you see the literature, 8 to 10% chance of development of VTE, venous thromboembolism.
What exactly is your prophylaxis protocol?
Prophylaxis,
How long
that
are
is
you?
12 hours before we put this, 12 hours before we do the delta variant, 12 hours before 5,000, the prophylactic dose. And after completion of the surgery, 6 hours after surgery, normally, usually first post-op day, we put the another, continue the dose for 5 to 7 days minimum. If the patient is high risk, we continue to 2 weeks to 3 weeks. So that is our protocol we follow.
Okay. Rohit?
Same thing, sir. Most of it, whenever we have a left-sided colon, the mechanical and antibiotic prophylaxis is always there. Most of our preparations, and it is always asserted. It's usually 48 hours before, and then we allow them liquid diet in case to be there. DVT prophylaxis same 12 hours before we start off. We start off with enoxaparin 40 mg subcutaneous, and then we give it immediately 12 hours after the surgery or within 12 hours, and then it is continued until they are in the hospital. And post discharge, during the discharge, if there's extensive pelvic surgeries, if the patient is not ambulating to the extent which we feel, then definitely it goes on post operative at least for another 1 to 2 weeks in the house with the home care people.
Is anyone using oral anticoagulants?
We are
No?
using. We are
Yeah.
using.
So the recommendation is 4 weeks actually. So nobody is using up to 4 weeks, only 1 or 2 weeks or 3 weeks.
No, we are using it for 4 weeks. We are giving enoxaparin same 12 hours before the surgery, starting within the 12 hours after surgery, and then giving it for 4 weeks. Whatever the amount of resection is there, we are giving it for 4 weeks for any abdominal pelvic surgeries.
The patient continues to take herself?
Yes, yes. We train the patient, they take it at home after discharge. It is a subcutaneous injection.
But one thing I can tell you, because if you see the literature and practice, there is hardly any literature from India. And as per the whatever literature available, the Indian people are less like to develop
Yes,
compared to Western people.
Yes, I do agree that DVT incidence is lesser in Indian, but still we give.
So there is
something that is less documented, is less reported, is less seen. That's all.
That is true. That is, you are right, Dr. Vaid, very right. So we hardly give, and our experience is very good. Hardly we see the patient develop DVT.
No, we have seen patient developing DVTs. But then since last 7-8 years, we are giving it for 4 weeks, and patients are complying. Once we advise them, they are ready to take.
So I agree that we actually do not have any good quality evidence to say what is the incidence of DVT in Indian patients. We are not routinely doing any Dopplers. So because clinically we are not seeing, yes, I agree, not enough maybe to really be advising across the board for 4 weeks as per the Western literature recommendation. Anyone else has any different practice, Dr. Deepti, Dr. Ambrish, or you are doing the same?
So just to know the incidence of DVT now in Indian patient, basically after the post, even after giving the prophylaxis, we have given thesis to my DNB student now that they will do the Doppler before the surgery, 24 hours, 48 hours after the surgery, and 1 week after the surgery, even on the enoxaparin prophylaxis, to see whether there is a clinical DVT or not, because there is no data available actually.
Yeah, Dr. Ashwin has asked again oral rivaroxaban, so I don't think anyone is using.
So actually, we used Xarelto once 2 years back, but then we had a case of GI bleed. It was not a Hypex ERS surgery. It was a remember gastric surgery, I think. And then we searched the literature. There is a incidence of GI bleed actually from Xarelto. That's what we find out that time when we compare with the low molecular weight panels, and then again we switched back to for abdomen surgeries. So we are not okay with Xarelto. I just don't know. We don't have much experience, but then that was the thing we find out.
So, sir, I'll just finish off two things. So initially what we were concluding it on that, and this, I think so there is no difference much of the prophylaxis. But when we were discussing, you mentioned about this Congress also. So what we are facing, the non-compliance and the most of the things we are worried about the drains, prophylaxis. So there should be some scope where we can just push in like that, putting a regular drain, instead we can put a JP drain, which is a soft drain, and it doesn't cause much problem to a patient, although it's not a standard and it is written as a protocol. So can't we just bring some more thing in the ERAS bracket, which makes patient, helps patient for the recovery, but it's not the part of, like the modifying the DVT prophylaxis, bringing these soft drains, bringing a small nasogastric tube instead of putting a 16 number and giving a trouble. A 12 sometimes is good like that. So just we should start thinking that I want to add here.
Yes, I mean the one of the points that are likely to be discussed in the Congress is making the guidelines based on the surgeries. So yes, definitely I'll keep that in mind. My last word, evidence in support or against the mechanical ball prep, the studies are conflicting. You can, depending on what you believe, you can find evidence and go with it. Mobile trial 1 said it's not enough. The 2 said yes, it has benefit. So more and more trials are coming up. So yes, as of now, left colonic resection, there is guidelines do support resection. But yeah, as more and more evidence accumulates, maybe we'll get wiser, or maybe we'll have more tailor-made guidelines in times to come. If anyone else has any competing comments from the panel, otherwise I think we are just finishing in time.
There's a question in the chat box.
What antibiotics? Okay. Okay, so the panel may answer. What antibiotics, Rohit?
Rifagat. What it comes? Yeah, so we use the Indian version. If not, that is not there. We use just give Ciplox-TZ.
Okay. Anyone else using oral antibiotic preparation? Which is
Yeah, we are giving Oflox OZ.
okay.
We do not give.
We don't give. We also don't give.
Same here. I also don't give no oral antibiotic. I have a different opinion about bowel preparation, if I may. Can
Yeah.
So I heard many of our panelists saying that they don't give or selectively give bowel preparation. But if you are doing a pelvic peritonectomy and in the event that you have to do an AR, so because of the disease in the pelvis, so and majority of the deposits, when we always discuss about doing an anterior resection during surgery. So contemplating on that thought, I have always, like in our institution, even in TMH, I think bowel preparation was mandatory a day before, maybe in the and be followed by clear liquid or liquid diet till morning, whatever. So bowel preparation about that, because we are in that point of when that patient may end up having a bowel resection, may end up having a rectal resection. So and using so bowel preparation, I am more liberal, and I feel like that is, again, it may differ from person to person. Second, about anticoagulation, it's preoperatively Clexane 0.4, and then maybe DVT stockings. Post-operatively, maybe this the pump, DVT pump can be given for immediate post-op, and from day one, based on drains, again Clexane can be restarted. Is what I find, or heparin, if depending on the institution's protocol.
Dr. Aruna, I give the house back to you. Do you want me to conclude? So thank you everyone for joining. And if there are more questions, please feel free to post it in the group and we'll definitely try and answer
Yes.
on there.
So thank you again. Thank you all for this wonderful discussion on ERAS. And the crux is that some ERAS for all, depending upon patient to patient, and we need to develop our own. As more and more papers are coming from our country, we should get these kind of more papers from our country for these modifications like the JP drain and this small vials tube. So we should encourage all those things. We should have more of our data as we are seeing. So thank you all and have a wonderful weekend. Please write us if there are any questions and we'll definitely get back to you. Thank you so much.
Thank you. Thank you.
Okay, thank you everybody. Good night. Thank you.
Thank you, sir. Thank you, everybody.
Thank you.
Thank you, everyone.